Good evening, everybody. Welcome to Diabetes India Initiative on learnings from the EASD. This is the last day of the learnings. We started on 23rd and 27th. Today we have a couple of topics of interest, especially type 2 diabetes. The first talk would be a type 2 diabetes and CGMUs. The second talk will be from invited speaker. We'll have that as a recorded talk. The second talk would be by Dr. Purvi Chawla on therapeutics of therapeutics in the management of obesity. Then we have a panel discussion moderated by Dr. Akash Singh, along with the panelists Dr. Manoj, Dr. Supratik, and others. The first talk, which will be delivered, can I have this CV of the first speaker, please? Yeah. So Tadej Bertolino, he's from Slovenia. He's completed his clinical fellowship from Loyola University of Chicago, currently consultant at lead Department of Pediatric and Adolescent Endocrinology at the University of Ljubljana. I don't know, I'm not pronouncing it right. I really don't know how do I pronounce that. PI has been actively involved with ISPAD and many other. He has authored more than 322 papers. He has a cumulative H index of 1959. He is most profound. He received the profound honor to present with the D decoration for the year 2023. So we will have his recorded talk over to RX team to play the recorded talk, followed by a talk from my friend Dr. Purvi, who will be talking on newer therapeutics in the management of obesity.
Dear colleagues and friends,
Right.
It's a pleasure for me to present to you the lecture from the EASD Diabetes India Symposium this year, entitled CGM in Type 2 Diabetes Management. I have no disclosures in relation to this lecture. However, those are my general disclosures for you to review. For today, I would like to propose to you a little bit of a background. The question whether glucose is harmful. Do we have any evidence for CGM in type 2 diabetes management? And perhaps touch a little bit the time in range or even time in tight range management philosophy. So is glucose harmful? Well, this registry study from the UK Biobank that included almost 1/3 of a million of the British people and genotyped them for a A1C associated then with the risk of cardiovascular, all in people without diabetes, with lowering average glucose on the lower edge, let's say A1C approximation of 4.9 versus the upper edge of normal approximation of 5.8. There is a 3 times difference in cardiovascular risk. So this genetically proxied A1C already in people without any diabetes is conveying a 3-fold increase in cardiovascular risk. If you look at the same UK Biobank, here you have people with type 2 diabetes, 12,000, people with pre-diabetes, 47,000, and people with normal glycemia, 250,000, you can see actually exactly the same. So the cardiovascular risk is increasing with increased glucose in a 2 to 9-fold increase. This is atherosclerotic cardiovascular. You can see type 2, 16 times increased risk. If you have pre-diabetes, 9 times increased risk. Here you have chronic kidney disease from 3 to 8. And here you have the heart failure risk, where you have 2.6 to 4.7. And if you go further, here you can see that there is a gradient between normal glycemia and type 2 diabetes that starts within the normal range of glucose. And if you go to another study in UK Biobank in relation to the brain, which I believe is of particular interest, this is 39,000 people included here. You have males and females equally represented and all other risk factors in addition to glucose are listed, please note that the cognitive was highly related in a fully adjusted model, as well as in here you have cognitive, and here you have the MRI brain structure difference. Please note that in a fully adjusted model here, for every covariance in existence, as you can see, including the ApoE4 genotype, it was a very high significant correlation between A1C model and between either cognitive impairment or structural impairment of the brain. And this is the registry of the Swedish type 2 population. As you can see here, 1.8 million control, 1/3 of a million with type 2 diabetes. It is an obvious risk for vascular and non-vascular dementia in relation to diabetes. And please note, it increases with increased mean glucose, here up to twofold in this population. The higher the mean glucose, the higher the risk for either vascular or non-vascular dementia. So elevated glucose is harmful. This is the first important message. So do we have evidence that CGM helps in individuals with type 2? And we do. This is the JAMA study from 3 years ago, and this is the basal only. Please note a very clear difference when they were using CGM or SMBG with all other things similar. But then this is a basal only study that's very recent and comes from Denmark. Please note 83% were on basal only and 66% were using GLP-1 receptor agonists. So they were on optimal therapy. Despite this, the time in range when CGM was used was plus 15%. And there was a lower total daily dose of insulin, and there was a weight loss associated with the use of CGM. So all three benefits together in people that were 2/3 of them already using GLP-1 receptor agonists. So a very, very favorable outcome at 12 months of usage. And here is another study demonstrating non-insulin users, if you want. Just focus on this group, please. So non-insulin users, at the beginning, 52% of time in range. At the end of the study, 12 months, 72% of time in range. So from very low to in target. Of course, this was significant. And a big reduction of time above range. So we can clearly say a preservation of the cardiovascular risk and brain damage risk. And this is an interesting study because it only used CGM and an advice on food, healthy food in general sense, and post-meal CGM values. And with only this, you can see a clear reduction in glycated hemoglobin. So the only intervention here is the CGM and the food assessment. But not only the primary endpoint, which is A1C, that was diminished by 0.5, which is a very clinically relevant reduction. Also, the fasting glucose, of course, went down, and the body weight, to the surprise of many, with only this intervention with CGM and the food, came down. Of course, with lower weight, also the blood pressure went down significantly. And this is the immediate study, again, type 2, inadequately controlled on insulin. You have a 10% increase in time in range. Importantly, an 8.5 increase in time in tight range. So most of the increase was in time in tight range, as you can see here from the data. Not only the glycemic values improved, but also the participant-related outcomes were significantly better. So no additional stress, but better satisfaction, which is also very important. So not only the diabetologists were happy, but also the people that used it were happier with the usage. And here, a very interesting study using the Canadian private payer claims, a very large study, again, as you can see here, thousands of participants. And as you can see, those that used the CGM progressed to therapy intensification considerably sooner. So almost double as fast, or even more than double as fast. So CGM helped intensification of therapy, higher progression to a better therapy. And here we have now formal meta-analysis of the evidence. This is from Diabetes Care this year. This is CGM versus SMBG. As you can see here, a very, very clear favor, significant favor of the use of CGM. And this was true for intermittently scanned CGM, also in this particular meta-analysis. The second published in Journal of Clinical Endocrinology and Metabolism here, separately CGM and intermittently scanned CGM, a difference in A1C of 0.3%. This is a very universal decrease with the use of CGM in type 2 diabetes. An increase in time in range of more than 10% on average, a very favorable, significant outcome again. And here, time in hypoglycemia, even slightly, although not significantly reduced. The third study is a meta-analysis of people with type 2 diabetes. Here we have A1C, again, 0.3. So this is a DTT paper, exactly the same outcome, an increase in time in range in this particular meta-analysis, 8.6%. As you can see here, of course, both significant. Interestingly here, time above range, of course, significantly decreased, but also time below range, below 54, decreased by 0.25%. With this meta-analysis, also the participant satisfaction was assessed and was significantly improved in this meta-analysis, as you can see, by 0.75 points. And here, Diabetologia, the fourth meta-analysis published, exactly the same outcome. Please note, 0.3% decrease in A1C here. This is the real time, this is intermittently scanned, and very importantly, separately non-insulin users, exactly the same outcome. Please note, 0.3%, again, significant non-insulin users with CGM, type 2 diabetes. Time in range increase, time below range increase, and this both, of course, is significant and clinically meaningful. I like this statement here, this paper, in older adults. As you know, we have more and more older individuals with type 2 diabetes, and here they say they are particularly important for the use of technology. I really like it. And also this statement published recently by an American group of experts saying CGM should be made readily available to all individuals with diabetes. Payers and policymakers should catch up. So we all should catch up, because also researchers need to catch up to provide evidence for the importance of CGM in type 2 diabetes for all individuals. Importantly, intermittent use of CGM was also discussed, and particularly this paper emphasizes its use in India. I was very, very happy to be able to participate in this study and paper led by Professor Banshi Shabo, and also, as you see, most important people from India participated. As you can see, also the use of CGM even 2 years, 3 years ago was already widespread in India. There are possible disadvantages of CGM, particularly related to the skin troubles that some people experience. As you can see, overall, approximately 3% of people stop using CGM because of skin problems, but most stay, so around 97% stay, and these skin troubles many times are transient. And here is a general appreciation of people with diabetes. Please focus on the second group, 1,100 people, and the third group, 1,200 people, non-insulin users. Time in range for them is the most important clinically meaningful information that they get. Finally, a meta-analysis on the hypoglycemia fear survey, a very, very clear advantage of CGM. But let us focus on cost effectiveness, because this may be of particular importance for many of us. And here we have data from France. This is the first report in Diabetes Care, 74,000 participants, type 1 diabetes, minus 49% of acute events, type 2 diabetes in the first year, 40% less of acute events. This, of course, is immediate cost saving. If you go to the second year, please note exactly the same outcome for type 1 and type 2, a 50% reduction after 2 years, of acute events. And please note that the attrition rate was very low. So at 24 months, 88% of all users with type 2 diabetes are still using it. And finally, this is the basal-only group here. As you can see, 60, so this is all-cause hospitalizations, and this is diabetes-related adverse events, so 60% lower, and therapy intensification faster. So a very clear message of the benefit and cost effectiveness. And this is a different country here. This is the non-intensive diabetes therapy, so without insulin. Please note, this is acute diabetes events here before and after CGM. Please note the huge difference in acute events, and this is all-cause inpatient hospitalization. Also a very significant decrease when CGM was used. And this is actually now already 3 years old, and even then, this was the outcome that was very favorable. 10,000 people included in this study. So finally, what are our targets? So here we have a paper actually that this is the question whether CGM metrics are associated with the important outcomes that we want to follow. Here we have actually a study with normal albuminuria, microalbuminuria, macroalbuminuria, not a very big study, but an interesting one. As you can see, of course, A1C was significantly different in between these three groups, but more importantly, time in range was very significantly different in between these three groups. When you model this and control for all covariates in this study, please note that the A1C lost significance. However, the GMI and time in range retained. So both are a much better predictor of the risk for micro and macroalbuminuria. And this is of course important because it matters what we use to predict the risk of these individuals. How's about time in tight range? Well, if you use modern dual agonists in this particular study, the time in range was more than 90%. So perhaps it's not the best marker. If you use time in tight range, as you can see here, it is 73% and discriminates the value of these novel therapies better than the regular time in range. And it's also an achievable target for these modern therapies in type 2 diabetes. What is also important is that when the disease advances here from the initial down to the overt diabetes, most of the loss is actually within tight range. Please note that most of the initial loss in glycemia is in tight range. So the tight range is a very important early marker of the loss of control in early type 2 diabetes. And of course, finally, also for the outcomes in trials, luckily time in tight range is an option, so we can use it as an outcome in trials that use modern therapies. What's about the perspective? Well, we recently published this Nature review paper, and please note we says CGM is for all people with type 2 diabetes. This is the most important message. Of course, some need to use it continuously, some need to use it intermittently, as was discussed, particularly when we use it in very early stages. Perhaps intermittent use with the initial GLP-1 receptor agonist or SGLT2 medications is appropriate. But then, of course, when somebody starts to use more relevant therapies, more dangerous therapies, then people on insulin therapy, of course, continuous use is actually advocated. Evidence generation will drive this paradigm further, so please collect the data, provide more evidence. Also for India, this is extremely important for all of us. Finally, ICGM standard by the FDA is a very important metric. We only want to use high-quality CGM devices, so we know that our advice to people with type 2 diabetes is reliable and accurate. So please choose those devices that follow ICGM standard or a similar standard of high quality of CGM devices. Allow me to propose a couple of conclusions to you. First, hyperglycemia, high glucose, is the primary cause of short and long-term diabetes complications. CGM helps all individuals with diabetes, of course also all individuals with type 2 diabetes, regardless on the therapy modality. Time in range is a manageable target. It is something that people with diabetes can relate to and can act upon. So it's perhaps the best manageable diabetes target and the easiest way to describe glycemia to people with diabetes. And finally, perhaps time in tight range, which is 70 to 140, may be a marker of an excellent control and perhaps even remission of type 2 diabetes. You're warmly invited to ATD Asia. It's still time, November 18 to 20. It will be a very exciting meeting, the first ATTD based in Asia, warmly invited, and of course invited to ATTD, the global one in Amsterdam, next March 19 to 22nd. With this, thank you very much for your attention. Thank you for all the good work you're doing in India. This is my team that work while I talk. Thank you very much again for your kind attention.
Thank you for the talk. Do we take questions, or is Purvi ready to go on? Okay, another 5 minutes. We'll do that. Manoj, you can start. Dr. Akash Singh, you can start the discussion with Manoj and whoever is available right now. We can take the. We'll ask Purvi to talk after 5 minutes, sir. You can
So,
initiate.
the one thing which is very important is that CGM is coming up very much in management of type 2 diabetes. But the main emphasis in CGM in type 2 diabetes has to be patient involvement, patient self-education, and patient initiated decision making in the nutritional, especially the nutrition part and the medication adjustment. So, what is your take on this, Manoj?
Yes, Dr. Akash, thanks for the question and absolutely important and relevant, especially since the last few months in India. Also, the trend has been now to gradually move from the blinded retrospective professional CGM to the real-time use of CGM. If we look at the trend in the West and what Dr. Tade was referring to, most of the data, the predominant use of CGM now across the world is of the personal real-time CGM. In India, it was traditionally more professional blinded CGM, but as I said, the trend is now towards real-time CGM. And that is where the involvement of the patient becomes extremely important. Most of us would agree that when we talk even about other means of monitoring like SMBG, we would often hear from our patients that everybody has 2, 3, 4 glucose meters lying at home, but after a while they stopped believing it because either they landed up with errors due to improper training and use, they would waste trips or get wrong readings and then stop believing in the system. Similarly, for the CGM as well, when somebody starts using CGM, to have a conversation with them, to have a little bit of onboarding, just the way we do for insulin pumps, there actually has to be a program of CGM onboarding for patients using real-time CGM, where we are explaining to them when to see the data for those devices which require scanning, how often to scan, when to scan, how to react to the arrows, how to react to the readings, so that they understand not to overreact to the level 1 TBR seen very often in the day 1 and day 14. At the same time, not to overreact to a glycemic spike that they may pick up 1 hour after a particular food. So absolutely right that using CGM requires us to have the conversation just the way we evolved to using structured SMBG. CGM also requires conversation and training and explaining to the patients what their data is and how they should learn to react to it, especially the ones using it for insulin and basal boluses, and how to use it best to their advantage.
If we have difference in the glucose management index, the GMI, and the HbA1c, so what should be the interpretation of the same?
Again, a great question and something which requires clarification. Before the GMI was put up there, you had the metric as estimated A1C. In fact, if you see the reports, still very often the reports in India will still call it estimated A1C. Some of the softwares have improved to calling it the GMI. So estimated A1C would very often give a wrong idea because based on the values that you would see in that 7 days or 14 days, it would give an approximate A1C. And very often the patients would think that this is my A1C or expect that at the end of 2 months when they do their HbA1C, it should come to what the CGM had predicted. So it was more of a predictor, and which is why the terminology has now changed to call it into a glucose management indicator, which is GMI, right? So most of the softwares have again been updated to include GMI. In India, some may still show estimated A1C, some may show GMI, but eventually it will all be GMI, which is more of an indicator that based on the profile that the patient is seeing on those particular days, where is your A1C likely to be? But to avoid the confusion with HbA1c, they have rightly so changed the terminology.
To extrapolate this question, does the GMI negate the because the HbA1c dependent on the several parameters, whether is a live RBC lifespan, and it may be erroneous in many cases, hemoglobinopathy, CKD, and all. So, does the GMI stand better than HbA1c in these?
So, well, GMI is more of a CGM based predictive metric. Can it be better than HbA1c? Well, let's really remind ourselves that till we get more evidence, HbA1c continues to be the gold standard metric of long-term control. All your data and reports linking better glycemic control and complications are still HbA1c based. We do have TIR data relating TIR to complications, that better TIR would lead to lesser complications, but this is extrapolated data based on predictive models from the DCCT. So till we get more data on that aspect of linking TIR and glycemic variability to complications, HbA1c would be the gold standard. So GMI, I would say, is something which is a predictive value. It's again, as the name suggests, a glucose management indicator, and that is what we look at. That this is the indicator of where we stand. But today, looking at the CGM reports, there's what we need to evolve into is looking at more than one thing. Are we supposed to look at only the TIR metrics? No, we're going to look at the full TIR, but we also are going to look at the GMI. We are also going to look at the percentage CV to look at the standard deviation, and anything less than 36 is recommended to be good. I would say it should be less than 30, at least in the Indian context. And then you start looking at percentage sensor used and the time of the day and so on. So GMI doesn't replace HbA1c, but just an alternative indicator of the sugar profile.
Which are the conditions in type 2 diabetes where the CGM is more of an indicator specifically?
Does Supratik want to take that? Else, I'm happy to answer if Supratik wants to take that. That's fine, as he's joined in as well. So,
so if you could repeat that question again one more time, please.
Which are the type 2 diabetic patients where CGM would be indicated more often?
Yeah, so which are the conditions related to type 2 where we'll be using CGM? Is that the question?
More often.
Yes, Supratik. More often use of type.
More often.
Yeah.
Okay.
And
So I think there are certain cohorts of patients who benefit from using CGM more often, as we had been talking about, like the CKD patients in particular, where we see a lot of fluctuations who are on, say, basic bolus therapy. Also, sort of, those patients were more vulnerable to hypoglycemia in general, um, either on insulin therapy or on other medications which sort of, predispose them to hypoglycemia. Uh, those patients with, advanced liver issues as well on insulin, and also elderly individuals for that matter, so all of these patients would probably benefit from using CGM more often than others. But in general, as we said, we need to encourage anyone with diabetes to, just to understand their glycemic pattern, to undergo a CGM at least once, even at the stage of pre-diabetes, and definitely during diabetes as well.
Dr. Akash, I may like to add to that. I think just individuals where the glycemic variability on SMBG and HbA1c is very wide. I mean that's one of the basic indications, and also there's upcoming use in pre-diabetes. So we've been doing a lot of pre-diabetes also with CGMs, and I think it's a great behavioral tool and helps self-reflection and changes based on the patterns understood.
To present. Very
Thank you, Akash,
Shall
for
I
those
share mine?
questions. Yes.
Yeah.
Thanks.
Dr. Akash, we'll continue the discussion later. I think Purvi is ready for the
Okay.
talk. Please invite Dr. Purvi Chawla to go on with this with the talk, Future Insights of Therapeutic Strategy for Obesity Management. Over to you, Purvi. I don't think Purvi needs introduction here in this panel. Dear Purvi, go ahead, please.
Thank you. And I'm just filling in for Dr. Wasim Hanif sir. And of course, I have my own slides. I'm not, being a physician forum, I'm going to focus more on the pharmaceutical or the therapeutic strategies that involve drugs rather than surgical approaches and other things. So without much ado, of course, global prevalence of obesity is really increasing and it's on a red alert, as we all have well understood. And so is the case in India, even though relatively speaking, India may not be on the radar, but we know that right from where we were, there has been a whooping increase in the prevalence of obesity and especially abdominal obesity across different states of India. And these numbers are staggering. Again, we also have understood well that obesity and cardiorenal metabolic diseases are not only interconnected, they coexist and also amplify one another, resulting in a significant burden on our patients' lives. Namely, type 2 diabetes is a very prominent one, also cardiovascular disease, and now the more and more attention that we are giving to MAFLD, very well justified. Look at that, 75% of our patients living with overweight, obesity, and diabetes would have MAFLD. So these are just to name a few, but we know that the multimorbidity with obesity is really massive. Again, this is just an example from the Endocrine Society of India that weight loss targets based on comorbidities are right from even as minimal as 5% weight loss can give you metabolic benefits like reduction in HbA1c or sugars, and of course, all the way to 15% and more would be required for any kind of remission in diabetes expected. And again, lots of other benefits as well, with reduction in the burden of hypertension, dyslipidemia, NAFLD, etc., etc. So even as less as 5% is beneficial, but anything above 10, 15, 20% is definitely what is good for overall health and reduction in the an increase in the long-term benefits of weight loss. Again, if you notice this table, the BMI cutoffs for managing obesity in South Asians, the role of pharmacotherapy is right as we cross the BMI of 25, which would be grade 1 obesity as per the previous cutoffs. And again, grade 1, 25 to 26.9 kilogram per meter square in the presence of comorbidity associated with obesity, and thereon pharmacotherapy is completely justified. Again, we know that with this increasing burden, lifestyle interventions are the cornerstone of managing obesity, but may result in up to 10 to 15% weight loss. But 80% of that weight loss is usually regained within the first 5 years itself. Lots of factors driving this weight regain have also been identified and attributed to the hormonal changes and also the low resting metabolic rate. So 5 to 10% is what is beneficial, but definitely for the myriad of benefits associated, anything more than that is clinically significant as well. Now, bariatric surgery, as we all know, offers 25 to 30% weight loss with long-term weight maintenance as well. But of course, scalability is limited, and it cannot be that we have all patients undergoing surgery. And of course, the widespread access to the same is limited. And also the long-term complications or deficiencies associated with bariatric surgery also can be considered as disabling. But now our advances in understanding the enteropancreatic hormones have led to the development of the GLP-1 based receptor agonists, which are safe and efficacious for not only diabetes, but obesity management. And we know we have a variety of examples for that. We have been using the injectable ones, but we know that that would have been a limitation with a lot of our patients, and hence the quest to look out for more agents is definitely on. Now, just very quickly looking at this, this sort of meter, you can see that with all the older agents, even the combination therapy, which were not earlier even available in India, but now we do have phentermine topiramate combination also. These were able to bring about only up to 10% of weight loss, and we had nothing until the advent of semaglutide and tirzepatide, where we could have expected medically achieved weight loss of more than 10-12%. So tirzepatide, which was one of the first dual agonists approved, has achieved that sweet spot of more than 20% weight loss, comparable with surgical procedures, namely the sleeve gastrectomy. So thus, with this, we have a large pipeline of enteropancreatic hormone-based pharmacotherapies, and these are under development as they may complement the action of each other and along with GLP-1 receptor agonists, which have been the first or a very, very safe and well-established target for obesity management. So tirzepatide was the first combination of enteropancreatic hormone, namely the dual GLP-GIP receptor agonist, which was approved for diabetes management and then subsequently for the treatment of obesity as well last year in November. And this ushers in a new era of singular, dual, and triple agonists for obesity and related comorbidities. Other non-enteropancreatic hormone-based therapies are also available, like bimagrumab and growth differentiation factor 15, GDF15. They are also under investigation in the clinic. So just to cut a long story short, it's the GLP-1, which the gut hormone, which is the backbone of all these therapies that are being developed for obesity. And you can see that either singular or dual or triple combinations are being developed with the GIP agonists, amylin agonists, then you have the glucagon agonists, the peptide YY agonists, and then the triple combination of GLP-1, GIP, and glucagon agonists. And you can see this is a list of molecules that are development. The pipeline looks extremely exciting, and at least 2 of them are in phase 3 on the verge of reaching for that final NDA application and approval. So again, just to elaborate on that, GLP-1 agonists bring about reduction in food intake because of increased satiety, also bring about glucose-dependent increase in insulin secretion, reduce the glucagon levels, and gastric emptying as well. So with these primary effects of GLP-1 agonists, they have been successfully combined with either GIP agonists or the glucagon agonists, amylin agonists, PYY agonists, and GIP antagonists also. And let me walk you through this very exciting pipeline that we have. And you can see I've enumerated in this diagram, all the effects and the complementary or synergistic effects that can benefit or bring about incremental weight loss when we combine these targets together. So this is, you don't have to go through the details, but these are all the molecules which are in the preclinical or just about entering the clinic phase. And then you have 9 phase 3 trials going on with either, higher doses of approved molecules or just new molecules by themselves for obesity, diabetes, also cardiovascular outcomes, even the metabolic dysfunction associated liver disease and whatnot. And we have 10 in phase 2. So this is a really exciting era for bariatric physicians, if I may, to be able to use all these tools in the next few years for weight loss. And in addition, I just wanted to highlight there is a phase 2 molecule from Boehringer Ingelheim, which is survodutide. Then you have from Zealand Pharma, a GIPR agonist, which is in the preclinical phase. You have glucagon analogs from Hanmi Pharmaceutical, which has just entered the phase 1. You have a couple of leptin sensitizers also, which are in phase 1 and the preclinical phase. And then you have a couple of the Y2R agonists or the peptide YY analogs, either in combination or by themselves in phase 1 and phase 2 in the space of obesity from Novo Nordisk. And you have those targeting the ghrelin pathway and other appetite suppressants as well, which are the GDF15 agonists from Novo Nordisk, Lilly, and Janssen in phase 1 for obesity and diabetes. So with that, I go into the details of some of them. The GLP-1 receptor agonist, we know subcutaneous liraglutide. We know all these effects. I just talked to you about them. Subcutaneous liraglutide 3 milligrams once daily was the first one approved. And now we have semaglutide 2.4 milligrams once weekly injectable form, which has been approved for obesity, and a higher dose of subcutaneous semaglutide is currently being assessed in a phase 3 trial, that is 7.2 milligrams once weekly injectable semaglutide. We also know that there is an oral form available and up to 14 milligrams is available in India for diabetes, and we know the weight loss effects of the same as well. A 68-week phase 3 trial of oral semaglutide 50 milligrams versus placebo found that there was 17.4% weight loss with semaglutide as compared to 1.8 in the placebo arm, with improvement in multiple cardiometabolic risk factors. And in diabetes patients, it was able to bring about 9.8% weight loss versus 5.4% with 14 milligrams oral semaglutide after 68 weeks of therapy in the Pioneer Plus trial. So we know it also caused an associated whooping decrease in HbA1c of 2.1% at week 68, as compared to 1.3% with oral semaglutide 14 milligrams. So we know oral semaglutide 50 milligrams is on the brink, and all these trials are going to give us more and more data and probably approval as well. Oral GLP-1 which is orforglipron. It's a partial biased agonist, which means that there is potent G protein activation as compared to the beta arrestin recruitment at the GLP-1 receptor. That's the way the GLP-1 molecule interacts with the receptor. And there's also preclinically glucose lowering has been established. It's now being developed as a daily oral therapy adjunct to diet and exercise to improve glycemic control and also for weight management in those without diabetes for the indications that I just mentioned. Orforglipron is a non-peptide oral GLP-1, and it's a small molecule, which means that the lack of availability and the cost that deters us from using GLP-1s is anticipated to be improved with this molecule. The phase 2 results have also been very encouraging. In a 36-week study at doses from 12 to 45 milligrams, there was a dose-dependent weight loss of 14.7% as compared to 2.3% with placebo, and corresponding improvement in cardiometabolic risk factors as well. In those with diabetes, again, orforglipron was successful, and there was a meaningful change in HbA1c as well. Similarly, we have danuglipron also, which is from Pfizer. It's in the phase 2 currently. And 16-week study of danuglipron in those who are overweight, obese, and have diabetes. It found up to 4.2 kilogram weight loss at the highest dose of 120 milligrams given twice daily as compared to placebo. And at these doses, there was more than 10% weight loss as well, but also very high percentage of discontinuation rates due to gastrointestinal side effects seen. Hence, danuglipron will not be used at these high doses, but is going to be developed further at the lower doses. Phase 3 trials with oral semaglutide or orforglipron and also danuglipron are ongoing at the moment. Next, we look at the enteropancreatic hormones, which address diverse metabolic actions. And here we've leveraged upon GIP, glucagon, and amylin, and peptide YY, and also antagonism at GIP receptor. And let me go through some of them. GIP agonism, well, GIP is secreted by the K cells in the jejunum in response to food intake, and its physiological role includes stimulation of insulin secretion, increased glucagon, increased lipogenesis, and enhancement of the lipid buffering capacity. What that all means is that in diabetes patients, there's an impaired ability of GIP to stimulate insulin secretion or to ameliorate hyperglycemia. And in a phase 1 study, a long-term GIP receptor agonist found that multiple doses over 4 weeks has helped with modest weight loss, but with no delay in gastric emptying, nausea, or vomiting. So combination of GLP-1 and GIP receptors is probably going to be more effective rather than GIP agonism alone. That brings me to the dual GLP-GIP agonist, tirzepatide. I already introduced that to you. It's a very, very potent molecule, has been approved for diabetes and also for chronic weight management. In the SURPASS program in those with diabetes, the mean HbA1c reduction by tirzepatide was to the tune of 1.9 to 2.6% across the trials, and 40 to 69% of the trial participants achieved more than 10% of their baseline body weight loss at the higher doses of 10 and 15 milligrams with no additional lifestyle interventions included. And again, it has been equally successful in the phase 3 and phase in the weight loss programs as well, with a meaningful, clinically and statistically significant 16 to 22.5% weight loss over 72 weeks, with no further plateauing as well, which means that if the trial had continued, the weight loss would have continued. So with that, we know that it's on the market, not in India though. Now looking at the GLP-1 receptor agonist, but the but the GIP-1 antagonist. There's a typo here. So GIP antagonism is also potential obesity treatment as seen in preclinical studies, improving the metabolic profile and reducing food intake that has been seen. We have an Amgen molecule, which is called maridebart cafraglutide, which is a monoclonal antibody and a GIP receptor agonist and a GLP-1 receptor agonist. Phase 1 trials have been encouraging, and phase 2 trials results are awaited. With that, we come to GLP and glucagon co-agonists. So building over that backbone of GLP-1, we have the glucagon specific effects as well. And we know it primarily is at the level of the liver, where there is hepatic glucose increase in the hepatic glucose production, increase in lipid oxidation and reduction in hepatic lipid synthesis, and all the other benefits that we see with glucagon agonism. We have preclinical study results that have shown very, very encouraging results in improving lipid metabolism and also weight loss. And survodutide from BI is again a dual GLP-1 and glucagon receptor agonist, co-agonist. And this dual agonism affects the liver through multiple direct and indirect mechanisms and may offer improvements in people living with obesity, MASH, and even liver fibrosis. It has shown very encouraging results in terms of weight loss as well as compared to semaglutide. You can see the dose-dependent reduction in weight and also HbA1c. Again, similar results in the phase 2 trial also, and is being now evaluated in MASH and fibrosis because of very significant results in terms of decrease in the liver fat content by 30% in 63% of the participants in the survodutide arms. It has got a fast track approval for MASH, and we will probably see the effects soon. Next, coming to mazdutide, it's an once weekly oxyntomodulin analog, again has caused a lot of significant weight loss in phase 2 trials as compared to placebo. And higher doses of the same are also being evaluated at the moment. So you have phase 2 and phase 3 trials at both the lower as well as higher doses, because significant changes in body weight as well as HbA1c have been noted with the same. Next, we have again a GLP-1 and glucagon co-agonist called pemvidutide. This is nothing special about this as compared to the rest, but the only specific effect is in terms of relative reduction in liver fat content up to 76% with 2.4 milligrams of pemvidutide as compared to 14% that was seen with placebo over 24 weeks. It's undergoing now treatment for MASH and also has received a fast track approval. Next, we have the GLP-1 and glucagon co-agonist efinopegdutide. Very confusing to spell out, but again, we have seen a reduction in weight, but no reduction in HbA1c with this, but there is preferential reduction in the liver fat content. And we will be seeing more trials of the same for obesity as well as for MASLT. That brings me to the next exciting era, which is with triple agonists with GLP-1, GIP, and glucagon. All three you are familiar with the effects, pharmacological effects. And let me tell you, retatrutide, which is a triple coagonist, is 3 times less potent on the GCGR, 9 times more potent on the GIP receptor, and 2.5 times less potent on the GLP-1 receptor. And this is in phase 3 at the moment, has shown fantastic results in terms of weight loss, as well as reduction in HbA1c as well. And the Triumph clinical trial program, which is over 80 weeks, which has been initiated in overweight and obese individuals with comorbidities like osteoarthritis, obstructive sleep apnea, or cardiovascular and chronic kidney disease, is now being undertaken, and we will have the results soon. Amylin agonism is also being leveraged upon. Pramlintide was the first synthetic amylin analog approved for diabetes, as you all may recall. That was also associated with an 8% reduction in weight. But craglintide has been a newer long-acting amylin analog which has shown promising results in phase 2 trials in terms of weight loss as compared to placebo. And even combination of amylin agonists with the calcitonin receptor agonists are in early stage clinical trials, and also in combination with semaglutide, which is an oral GLP-1. So this is the result with the craglintide and semaglutide, both at 2.4 milligrams given once weekly, again 17.1% weight loss as compared to either of them alone, used alone. And the phase 2 trial results in overweight, obese, type 2 diabetes subjects also has had very nice reduction in weight as well as mean HbA1c reduction. The gastrointestinal side effects commonly seen with this group of agents have been more with the combination, but nothing that led to any significant discontinuation rates. With that, the phase 3 clinical program redefine of CAGRI-SEMA is going on, and trials from India are also underway. So I can tell you that it's an exciting area. Next, we come to peptide YY. Peptide YY is co-secreted from the intestinal L cells along with GLP-1 in response to food intake. And it's also rapidly cleaved by the DPP4 enzyme to its active form that acts on the neuropeptide Y in the brain, or the Y2R, and results in reduced food intake and increased satiety. Again, singular agents as well as in combination are being developed. And that brings me to the end of the agents on the enteropancreatic hormone pathway. We also have some non-enteropancreatic hormone therapy, which includes the bimagrumab, which is a monoclonal antibody that stimulates skeletal muscle growth by blocking the activin type 2 receptor and is administered as a 4-weekly IV infusion. This is a promising area because we know that with weight loss, we also are faced with increased lean muscle mass loss. And these agents will help us stop that or improve upon that. As much as we recommend exercising to the patients, it's not possible to have a homogeneous response in terms of our patients following the advice, and hence agents like bimagrumab are only going to be more important. The same story for growth differentiation factor 15. Again, it's being it's valued for its increase in satiety and reduced food intake, and is being developed by at least 3 companies, Novo Nordisk, Lilly, and also Janssen. But let's understand that I'm not going to go through these details, but let's understand that because of our better understanding, we have such a strong pipeline of anti-obesity medications, not only the enteropancreatic hormones, but also the non-pancreatic hormones or non-pancreatic therapy. And tirzepatide has been the first dual GLP and GIP receptor agonist. The combination of amylin analog cagrilintide and the GLP-1 receptor agonist cagrisema, as well as retatrutide, which is the triple agonist, they are by far the farthest in clinical development and will be probably the first ones to get approved after what we have. The oral GLP-1 receptor agonists, which are the small non-peptide molecules, or which is danuglipron and orforglipron, are also going to be approved quite soon, maybe in the next few years. And the long-term safety, efficacy, as well as the impact on weight variability, as well as the access to oral pharmacotherapeutic agents for obesity management will all have to be considered and seen versus bariatric surgery that the patients can always walk up to if that is what they really want. So with that, I complete my presentation. Sorry for taking so much time, but it was quite an exhaustive list that I got.
Thank you very much, Corey. That was a very exhaustive presentation. Now, akin to diabetes, weight management or weight loss also requires targeting several pathophysiological mechanisms. And for that matter, initially we started with GLP-1, and now we are targeting multiple pathophysiologies in the form of GIP, in the form of glucagon, in the form of amylin, and the other derivatives. And this is an exciting era because we are now trying to equal bariatric surgery results, which are to the tune of around 30%. And with the current new pharmacological agents, which are the combination agents, we are about to achieve a weight reduction of around 15 to 20%. So as we progress the field of weight loss therapeutics, we will close the gap between the bariatric surgery and the drugs. And there may be a time where bariatric surgery may go completely out of the picture. Another thing is that a single agent like GLP-1 will have some tolerance to its effects as we proceed with the treatment. And to negate that tolerance, we need to use agents like cagrilintide and like GLP, GIP,
Yeah,
co-agonists to target the various pathological effects to the tolerance and the loss of effect of that drug. So this is there is a host of drugs basically, and as Dr. Puru has already said, that the ones which are going to come out very fast are the triple agents GIP, GIP, and retatrutide and cagrilintide. Another thing with these weight loss agents is that along with the fat, you also tend to lose some muscle, and therefore lifestyle modification, exercise, especially the resistance training, is very much advised for all of these patients which are using these agents, along with the proper diet and a distribution of macronutrients in the proper fashion, so that we save our muscles, which are the backbone of our health. I will like to I request Dr. Supratik to put in his comments and his take-home message before we conclude this session.
Very well summarized, Dr. Akash.
I think Dr. Supratik is not online, so if you can give a take-home message, and so we can conclude the sessions.
So great. Thank you for this opportunity, Dr. Banshi sir, Dr. Amit, and the entire team of Diabetes India. And I was very happy that Dr. Sanjay Reddy was there today to welcome everybody. Great moderation by Dr. Akash Singh and great inputs by the panelists as well. And nothing like sharing screen with Dr. Tade Battleino. Just want to summarize my talk by saying that lifestyle changes or interventions are the cornerstone for managing obesity, but we know that weight regain and weight maintenance are very big hurdles to maintaining the same. And pharmacotherapy steps in to rescue us from the same. Today, on the backbone of GLP-1 receptor agonists, we have a lot of combinations that are being developed, like combination with GIP, amylin, peptide YY, and glucagon, which bring about weight loss, as seen in the clinical evidence that we have thus far, to the tune of more than 15%, which is equivalent to bariatric surgery. Of course, we have data only up to 2 years at the most, and the long-term chronic effects of the same will also need to be studied, like we are studying with bariatric surgery outcomes as well. So yes, access, cost, availability, safety, efficacy, all those questions remain, but thus far we still have some options to offer our patients of overweight, obesity, in terms of medical management of obesity. But yes, adhering to a lifestyle change of reduced caloric intake and healthy eating, along with regular exercise, including resistance exercise, like Dr. Akash said, is going to be extremely important to preserve the muscle mass, as even with these weight loss agents, we do see reduction in the lean muscle mass as well. So that's all from me.
So I think we'll conclude the session. I thank Dr. Sajja Reddy for the welcome address and for initiating this session. I thank our excellent speakers, Dr. Pradesh Petrino, Dr. Purvi Chawla, for their very comprehensive and very informative and very excellent talks. We had a great input from Dr. Manoj Chawla and Dr. Supratik Bhattacharya regarding the questions posed, and they could offer further insights into the topics discussed. I thank Dr. Bansi Sabu, Dr. Aditya, and the entire team, Diabetes India, who has sort of brought this EASD snippets and short learnings from EASD live basically to the doctors across India. And lastly, I will thank all the doctors who will join this session to hear to these talks, because their participation really motivates us to go forward. Thank you.
रे 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 जिंदाबाद रे जिंदाबाद रे अहमदाबाद बाबा जोड़ा जे वो तूफानी रे के स्वाभिमानी रे अहमदाबाद रे तिमारमती नगरी छे कांटाओमां उछरी छे गुजरी छे लाखों चक्रव्यूहोथी पार हमेशा उतरी छे खाटू मीठू ने तीखू शहर रे के लीला लहर रे रे अहमदाबाद बाबा जोड़ा जे वो तूफानी रे के स्वाभिमानी रे ससो कुत्ता ने डारे रे ने पाछो मारे रे